Hello doctors, this is Dr. Hira Salman. Very good evening to all of you. So let's continue today our third session of pediatrics, and today we're going to start from this topic. This is abnormal genitourinary findings. So in abnormal genitourinary findings, first we are going to study this hydrocele. Hydrocele is very important for our exam point of view. So first thing which we should know, that hydrocele is a painless swollen fluid filled sac along the spermatic cords within the scrotum that trans-eliminates upon inspection. So 2 points are very important for this hydrocele. First thing is painless, and second thing it's trans-eliminates upon inspection. Other than that, it's a swollen fluid filled sac along the spermatic cord, but must remember painless thing and trans-elimination upon inspection. It's a remnant of tunica vaginalis, usually will resolve within 6 months. This is also a very important point, and must differentiate from inguinal hernia. So painless, trans-elimination, and resolve within 6 months. These are the 3 important points you must remember. Now coming towards varicocele. Varicocele is a varicose vein in the scrotal veins, causing swelling of papilliform plexus and increased pressure. So we can say that varicocele is actually a varicose vein. And where actually, and which vein? It's a varicose vein in the scrotal veins, causing swelling of the papilliform plexus. So papilliform plexus, they are going to be swelled, and we will see this varicose vein in the scrotal veins actually, which is nothing but a varicocele, and thereby increased pressure. The most common complaint is dull ache and heaviness in the scrotum. Symptoms are very important. Patient must be complaining of heaviness and dull ache in the scrotum. These are the 2 important points. Best initial test. We should know what is the best initial test, what's the most accurate test, the best initial diagnosis, the most accurate diagnosis, right? But best initial test is physical examination coinciding with the bag of worms sensation. So this point is very important, this word bag of worms. So whenever it's written bag of worms, varicocele should come in your mind, right? So bag of worms is varicocele because on physical examination, we have a sensation of this bag of worms if there is varicocele. And most accurate test is ultrasound of the scrotal sac showing dilatation of the vessel of the papilliform plexus. So when we go for the ultrasound, we'll see the dilatation of this papilliform plexus, which is more than 2 millimeter, and we'll say this is the most accurate test. So by physical examination, we can also confirm that this is varicocele, but the most accurate test, we will remember, this is ultrasound. Treatment is indicated for delayed growth of the testes or in those with evidence of testicular atrophy. So of course, if you see there is an evidence of testicular atrophy, if you see there is a delay in the growth of the testes, you should go for the treatment. That is highly indicated. Treatment is highly indicated when there is delayed growth of the testes or when there is evidence of testicular atrophy. So what points we are going to memorize in case of varicocele? First of all, is nothing but a varicose vein in the scrotal vein, which is actually causing what? Swelling of papilliform plexus. How the patient is presenting? The patient will be presenting with heaviness and the dull ache, right? On physical examination, this bag of worms is very important for the varicocele. You will go for the ultrasound. You will see the dilatation of the vessels more than 2 millimeter, right? And a treatment is of course indicated whenever there is delay in the growth or whenever there is testicular atrophy. Now always ultrasound the other testicle. This is very important point. All the boxes, these boxes are point to ponders. We must know what are these points. So always ultrasound the other testicle. It's not like that we will do only one ultrasound of one testis. No, we have to go for the ultrasound of both the testes. Varicocele is a bilateral disease. So if you see it on one side, it is likely indolent on the other side. Maybe not prominent enough, but it's there. So it's a bilateral disease. Now we're coming towards cryptorchidism. Cryptorchidism is an absence of one testicle in this scrotum. So if one testicle is absent, we can say this is cryptorchidism, and is usually found within the inguinal canal. You can always feel that testicle in the inguinal canal because descent is not there. So 90% of cases can be felt in the inguinal canal. Surgical treatment of undescending testes is recommended as soon as possible after 4 months of age. So see, as soon as possible after 4 months of age. No doubt we can wait up to 2 years, right? But sorry, we can wait up to only 1 year. But for congenitally undescended testes, and definitely should be completed before the child is 2 years old. So it's there like 1 year and 2 years. Some books says 1 year, and some, like it's also written here 2 years old. But we up to 1 year it should be descended, right? But we can go for the surgical treatment because it's indicated, it's recommended as soon as possible after 4 months of age. So after 4 months of age, we can always plan for surgical treatment of this undescended testes. But up to 2 years, after 2 years, we have to definitely go for, and usually up to 1 year, the testes should come down. If they are not coming down, then we have to surgically, surgically we have to manipulate it surgically. Other than that, it's possible that after 4 months we can also go for surgical, but it's always better to wait till 1 year, and up to 2 years we have to go for surgical manipulation. Now, cryptorchidism is associated with an increased risk of malignancy. Why it is so important, the descent of this testes? Because there is an increased risk of malignancy here, regardless of surgical intervention. If you won't go for the surgical intervention, definitely we have to go. But if we won't go, then what will happen? There may be a chances of increased risk of malignancy. Right? So this is very important. Cryptorchidism, this is the absence of one testicle because test is not descended. We can go for the surgical, option, but possibly as soon as possible after 4 months. But up to 2 years, we have to do something. And it's always recommended that wait for 1 year and definitely go for surgical manipulation after 1 year, but do it before 2 years, right? Now coming towards hypospadias. With hypospadias, the opening of the urethra is found on the ventral surface of the penis. So ventral surface of the penis, this is a hypospadias, and high association with cryptorchidism. It is associated with this absent testicle or undescended testicle. It may be associated with inguinal hernias, so there are the high association. And of course, hypospadias need surgical correction. Circumcision contraindicated due to difficulties in surgical correction of the hypospadia. So this is very important that we will not go, or we will not recommend circumcision in a case if the baby is having this urethral opening on the ventral surface of the penis, that is hypospadia. So must remember, in case of hypospadias, we will not go for circumcision. Right? Now, epispadias. Epi means the opening of the urethra is found on the dorsal surface. If it's on the dorsal surface, this is epi. Dorsal is above, so epi is above, right? And hypo is below and ventral is inside. So hypo is ventral and epi is dorsal. We must remember this point. Now, epispadias again is high associated. It's not associated with inguinal hernias, or it's not associated with the absence of testicle, but it is highly associated with urinary incontinence and must evaluate for concomitant bladder extrophy. So we have to evaluate a patient for this concomitant if there is bladder extrophy, because it's mostly associated with epispadias, and definitely it also needs surgical correction. So it's highly associated with urinary incontinence and concomitant bladder, and must evaluate for concomitant bladder extrophy as well in a case of epispadias. And the second point which we have to remember here, that the urethral opening is on the dorsal surface. Now we're coming towards developmental achievement. So developmental achievement, first of all, we have reflexes like sucking reflex. Baby will automatically suck on nipple-like object. Whatever the object is there, which is just like a nipple, baby starts sucking it. The grasping reflex, Babinski's reflex, in which there is toe extension. There's a rooting reflex. If you touch baby's cheek, the baby will turn out that side. That's a very common one. So these are all the primitive reflexes. Motor reflex, arms spread symmetrically when the baby is scared. That's very common one. Is stepping reflex, walking like maneuvers when toes touch the ground. And Superman reflex, when half facing the floor, arms go out. So these are all the primitive reflexes, and you must have seen all these reflexes up to 3 months of age, right? We're coming towards cardiology. In cardiology, we have first thing, that is cyanotic lesions. A 5-year-old boy is seen for routine examination by his doctor, but his parents have stated that lately he becomes short of breath while playing with his friends and has a bluish hue to his lips when coming back from playing. And the boy's teacher also says he finds the boy squatting while playing outside during recess. Which of the following is most likely diagnosis? He's just a 5-year-old boy and he's having this bluish this hue to his lips, and the squatting position while playing outside during recess. So which of the following is the most likely diagnosis? Either he's having ASD or patent foramen ovale or hypertrophic obstructive cardiomyopathy or TOF or restrictive cardiomyopathy. So here the correct answer is TOF. This is death spell. If the baby, the history of exercise intolerance and squatting while playing outside. So if the baby squats while playing outside, this is known as a death spell, right? And it's highly pathognomonic for teratology of phallic, that is TOF. So it is highly associated with TOF. So whenever there is a word squatting while playing outside, you should consider this death spell and the diagnosis will be TOF. The remainder of choices do not present death spells, such as squatting during exertion. None of the other diagnosis is not corresponding with this death spell or does not have this death spell, so definitely will go for teratology of phallic. Now coming towards the topic TOF. TOF is the most common cyanotic heart defect in children. So we have some cyanotic lesions, we have some non-cyanotic lesions. So cyanotic lesion, and in cyanotic lesion the most common, it is clearly mentioned here, this is very important for exam point of view, that TOF is considered to be the most common cyanotic heart defect in children. Now, TOF is a condition characterized by, there are 4 things which are actually occurring. Sometimes there is panted as well. So there are actually, but most commonly there are 4 things, 4 conditions which actually characterized by, which makes this TOF. And these 4 things are: number 1, overriding of aorta. Then we have pulmonary stenosis. There is right ventricular hypertrophy, and there is ventricular septal defect, VSD. So overriding, pulmonary stenosis, overriding of aorta, pulmonary stenosis, RVH, and VSD. These are the 4 conditions we will see in the case of TOF. Now, its cause is thought to be due to genetic factors and environmental factors. It is associated with chromosome 22 deletion. So this is, of course, it's a congenital thing depending upon the genes, depending upon the environmental factors, and they are mostly associated with chromosome 22 deletion. There is a deletion of chromosome number 22 here in patient, those who are having TOF. Now, how your patient is going to present if he's a case of TOF? Cyanosis of the lips and extremities. The first important symptom which you're going to see in your patient, that is a cyanosis of the lips and extremities. There is holosystolic murmur which is best heard at the left lower sternal border. Holosystolic murmur. Holosystolic, that's the same as pansystolic, means throughout systole, throughout contraction of the left ventricle, you're going to hear a murmur, you're going to hear a rushing noise, which is not a normal heart sound, that is known as a abnormal heart sound, which is also known as a murmur. So we are going to hear this abnormal heart sound throughout ventricular contraction, that is known as holosystolic murmur, and which is best heard at the left lower sternal border, because that's the position of the ventricle, right? Left ventricle. So left lower sternal border, because of the contraction or during the contraction of the left ventricle, we are going to hear this extracardiac heart sound, which is known as holosystolic murmur. And holosystolic means pansystolic, and pansystolic means that throughout the systole we are going to hear a murmur, and that is a murmur of TOF. Now, squatting after exertive activity. So whenever there is exertion or there is strenuous activities, the baby or your patient must be presenting with a squat position, and you are going to observe your patient at squatting position in order to relieve that exertion. Now, causes an increased preload and increased systemic vascular resistance. This decreases the right to left shunting, leading to increased pulmonary blood flow and increased blood oxygen saturation. So, see why this squatting? See, squatting after exertive activity, all these points, cyanosis and murmur and squatting, all these. So that causes, the stuff causes an increased preload. So preload, the whatever the load is coming towards the heart, that is a preload. This is going to be increased, and there is increased systemic vascular resistance, means peripheral resistance is high, and this decreases the right to left shunting, because VSD is also there. and all of this shunting is decreased, the blood is not coming from right to left, and this decreases the right to left shunting and leading to increased pulmonary blood flow. So of course, if there is decrease in right to left shunt, it means that the right ventricle is having large amount of blood but shunting is not there. So as a result, there will be increased pulmonary blood flow and increased blood oxygen saturation. We're going to see this oxygen saturation increase, and we're going to see this pulmonary blood flow increment, right? Why? This is all because of decreased right to left shunt, and this is all because of TOF. Alright, so how you are going to diagnose and what are the treatment you are going to offer? So chest x-ray showing a boot shaped heart. This is very important. Whenever it's written boot, always comes in your mind what? It should be TOF. Decreased pulmonary vascular marking. So marking will be decreased pulmonary vascular marking, and there's a boot shaped heart in case of TOF. Now again, there's point to ponder here. VSDs are common in down trisomy 21 to trisomy 18, that is Edwards, and Pediatrics, that is trisomy 13. So these are, it's not only TOF in which you are going to see ventricular septal defect, but there are certain other conditions in which also you're going to see VSDs, like in a case of Down syndrome, those who are having trisomy 21, those who are having trisomy 18 and trisomy 13, they also have VSDs. So VSDs is very common. It's not only occurring in case of TOF, but there are other conditions in which we will see VSDs. Now, surgical intervention is the only definitive therapy that we can provide to a patient in a case of TOF is surgical intervention. So that we have to memorize. Now coming towards tip, there are only 3 holosystolic murmur. Holosystolic murmur means the murmur, the extracardiac heart sound which you are going to hear throughout the systole. That is a pansystolic murmur. That's a holosystolic murmur, and we will hear this murmur not only in a case of TOF, but whenever there is MR, whenever there is TR, or whenever there is VSD, we will hear this murmur. So in case of mitral regurgitation, in case of tricuspid regurgitation, so you can just memorize in such a mnemonic that like in both the regurgitation, whether it's a mitral or tricuspid, you are going to hear this holosystolic murmur. And in case of VSD also, you are going to hear this holosystolic murmur. So holosystolic murmur means throughout the systole, that type of murmur, not only in a case of TOF patient, but also in case of regurgitation, whether it's a mitral or tricuspid, and in case of VSD also. So VSD is not only in TOF, but you're also going to see VSD in trisomy 21, 18, and 13. It means that those patients are also presenting with holosystolic murmur. Okay. The most common congenital, again there's a point to ponder here, the most common congenital heart defect in Down syndrome is endocardial cushion defect of atrioventricular canal. So they are pointing towards that in Down syndrome, VSD is not the very important thing, or the thing which is which we need to focus on, but especially in Down syndrome, we have some other common congenital heart thing, that is defect of endocardial cushion and defect of atrioventricular canal. And of course, we have the VSD also, but in combination with VSD, we have this endocardial cushion defect and we have this atrioventricular canal defect also in case of Down syndrome. So it's not only VSD there, but also endocardial cushion defect and also atrioventricular canal if it's a patient of Down syndrome. Now we're coming towards second thing, that is transposition of the great vessels. Transposition of the great vessel. This condition is characterized by an aorta that originates from the right ventricle. From where the aorta is originating? Aorta is actually originating from the left ventricle, right? But as the name indicates, we are dealing with the transposition of the great vessel. It means that instead of originating from the left ventricle, the aorta is originating from the right ventricle. That's why we can say this is a transposition. And pulmonary artery, normally it's coming out from the right ventricle, but whenever there is transposition, the pulmonary artery is going to come from the right, from the left ventricle. Normally it's coming from the right, but in case of transposition, it will come from the left ventricle. No oxygenation of blood can occur without a patent ductus arteriosus. That's very important, because already here there is transposition. So no oxygenation of blood can occur without a patent ductus arteriosus or atrial septal defect or VSD. That's very, very important to remember, that there should be patent ductus arteriosus. There should be patent, because ductus arteriosus is a communication between the pulmonary trunk and the aorta. We all know that lungs during intraembryonic, or especially in embryonic time period, lungs are not functional, right? So we have this communication channel in between the pulmonary trunk and aorta, so that the blood will not go through the pulmonary trunk into the lung. Instead of that, the blood will come from the pulmonary trunk into the aorta and supply to, and to the whole part of the body. So this patent ductus, this ductus arteriosus, is a communication channel between the pulmonary trunk and the aorta, so that whatever the blood is coming into the pulmonary trunk and which is actually going towards the lung will be shunted into the aorta, because lungs are not functional in intraembryonic life. So we will say that it should be very necessary in embryonic time period that this ductus arteriosus should be there. But soon after birth, as lungs are started functional, this ductus arteriosus should be closed. But if it's remain open, like in a case of transposition, we can say this is a patent ductus arteriosus, and it should remain open. Why? Because actually there is an anatomical defect, there is a transposition of the great vessel, and ASD also and VSD also. So this is very important. Now, TOF is the most common cyanotic condition in children after the neonatal period. Again, they are saying that TOF is the most common cyanotic condition. We should learn this, that the cyanotic condition, cyanotic lesion, and we should memorize which is the one which is actually the most common congenital cyanotic lesion. We should memorize this as a TOF, right? Transposition of the great vessel is the most common cyanotic lesion during the neonatal period. That is very important. During the neonatal period and after the neonatal period. So TOF is the one which is actually after the neonatal period, right? But this transposition of great vessel is the most common cyanotic lesion during the neonatal period. So if this question comes in your VNet, you should be very careful that what is the actual question is asking about. If the question is asking about the neonatal time period, then the cyanotic lesion, which is the most common one, is the transposition of great vessel, because this is during the neonatal time period. And after the neonatal time period, neonate means 1 month old baby, right? So after birth. So during the neonatal period means intraembryonically and between just soon after delivery till 1 month, this transposition of great vessel is very common. But after the neonatal period, after 1 month, if the baby is having all this cyanotic problem because of the overriding of aorta, because of the right ventricular hypertrophy, because of the VSD, because of the pulmonary stenosis, that is actually a TOF, right? Now, presentation and diagnostic testing, and we are dealing with this transposition of great vessel. So, presentation and diagnostic test, early and severe cyanosis is seen. So, if the patient is having transposition of great vessel, you will see early and severe cyanosis, and this is during the neonatal time period. A single S2 is heard. You will heard here, that's a heart sound, that's a S2 heart sound, and a single S2 is heard. Chest X-ray will show an egg on a string. Again, this is very important. If it's written boot shape, TOF should come in your mind. If it's written egg on a string, what should come in your mind? That's transposition of great vessel. It's just like egg on a string. Neonate must have an open ductus arteriosus. Again here, the treatment, for the treatment option, neonate must have an open ductus arteriosus. PDA should be there. They require prostaglandin E1 to keep the ductus open, because there is transposition and we have to shunt the blood, because aorta is coming from the right and pulmonary trunk is coming from the left. So of course there should be a shunt, and in order to minimize the blood pressure, right? So we can give prostaglandin even from outside as well to keep the ductus open, and NSAID we can also provide, especially indomethacin. So the main purpose of NSAID and the main purpose of indomethacin, see, we are requiring prostaglandin E1 to keep the ductus open, but we will not give especially this NSAID because an NSAID especially are contraindicated because they will cause closure of the duct. This is very important. They require prostaglandin E1 to keep the ductus open, and NSAIDs are contraindicated because they will cause closure of the ductus. This is important. We will not supposed to give NSAIDs especially indomethacin to this patient. Why? Because they will cause closure of the ductus, and here we don't want closure. Here we want patent ductus arteriosus, and for that we will require prostaglandin E1 to keep the ductus open. Now, two separate surgeries are necessary. However, each surgery carries a 50% mortality rate, and therefore only 1 in 4 will survive the surgeries, because there are two major things, right? The aorta is coming from the right and this pulmonary trunk is coming from the left. So the first operation will be to shift back this pulmonary trunk, and the second to shift back this aorta, right? So there are two different surgeries, and they're saying there only 1 in 4 will survive the surgeries. Now this box is actually points to ponder. Here we have different type of pulses. We have pulses alternans, we have pulses bigaminis, we have pulses bisferens, pulses tardus et parvus, pulses paradoxus, which is very common one, and irregularly irregular. So pulses alternans means sign of left ventricular systolic dysfunction. So whenever there is sign of left ventricular systolic dysfunction, you will always see this pulses alternans. In case of left ventricular systolic, means during contraction, if you're going to see left ventricle is not working properly, then you are going to see this pulses alternans. This pulsus bigaminis is a sign of hypertrophic obstructive cardiomyopathy, that is HOCM, HOCM. It's not HCM. It's hypertrophic obstructive cardiomyopathy. What is actually here in the case of HOCM? In case of HOCM, there's actually not a hypertrophy. There is actually, the ventricle, the interventricular septum is actually thicker than the normal, 1:4 times thicker than the normal. As a result, left ventricular cavity size is decreased. So this is the pathophysiology of HOCM. In HCM, there is hypertrophy of the left ventricle, but in case of HOCM, there is the hypertrophy of the interventricular septa, leading to decreased left ventricular cavity size, and that is the main thing in HOCM, right? So pulsus bigaminis is actually, we are going to see signs of hypertrophic HOCM signs we are going to see here. Especially in HOCM, we'll see this pulsus bigaminis. Pulsus bisferens, in aortic regurgitation, we'll see it later also. In aortic stenosis, we'll see this pulsus tardus et parvus. In case of cardiac tamponade, in case of tension pneumothorax, we'll heard this pulsus paradoxus. So you must memorize pulsus paradoxus, because it's very important, because pulsus paradoxus, we can differentiate it whenever there's a cardiac tamponade or there is tension pneumothorax, because in both of the cases you're going to hear this pulsus paradoxus. You're going to observe this pulsus paradoxus, cardiac tamponade and in tension pneumothorax. Irregular pulse we can see in case of atrial fibrillation. So these are just a point to ponder. These are the important points for a quick memory. Now, hypoplastic left heart syndrome. This is a syndrome consisting of left ventricular hypoplasia. See, there is decreased number of cells of the left ventricle, and mitral valve atresia. There is atresia. There is narrowing of the mitral valve and aortic valve lesion. So, especially it's a syndrome. Syndrome is a sum of deficiencies. So, we'll see here mitral valve atresia, we'll see here aortic valve lesion. Mitral valve and aortic valve are on the same side, right? Left. In between left atrium and left ventricle, they are the mitral valve, and in between the left ventricle and the aorta, they are the aortic valve, right? And left ventricular hypoplasia. So decreased number of cells of left ventricle, size of the mitral valve is decreased, and there are the lesions of the aortic valve. We can say all these three pathologies make a syndrome, and that is hypoplastic left heart syndrome. How your patient is going to present if it's a case of hypoplastic left heart syndrome. The presentation is absent pulses with a single S2. Pulses are absent, and we are only going to hear a single heart sound, that is S2. There is increased right ventricular impulse because there is a hypoplasia of the left. So we'll see the right increased impulse. Gray rather than bluish cyanosis. This is very, very important point to remember, that in case of hypoplastic left heart syndrome, you're not going to see the cyanotic cyanosis, that is the bluish skin. Rather you are going to say gray skin. inaudible murmurs. Here the murmurs are not audible. And hyperdynamic precordium. So precordium is highly dynamic, that is known as hyperdynamic, hypermobile. Now how you're going to diagnose your patient and what treatment you're going to offer? Chest X-ray. Chest X-ray will show a globular shaped heart. See, first of all, boot shaped heart. Boot shaped heart, what comes in your mind? Torf. Egg on a string, what comes in your mind? Transposition of great vessels. And globular shaped heart. So globular shaped heart, what comes in your mind? You should write all these in a point, right? Just make a note box here and write all these points. In case of hypoplastic heart, left heart syndrome, you're going to see globular shaped heart. Egg on a string, transposition of great vessel. Boot shaped heart, trachology of Fallon, right? So here chest X-ray will show a globular shaped heart with pulmonary edema. So pulmonary edema is also a very important thing is here, and echocardiogram is the most accurate diagnostic test. Again, very important. So chest X-ray will be the initial one, but echocardiogram is considered to be the most accurate diagnostic test. The only therapy is 3-stage surgeries or a heart transplant. So we only go for heart transplantation, or the only therapy is 3-stage surgeries in the case of hypoplastic. Why 3-stage? Because we have to look for the left ventricular hyperplasia, we have to look for the mitral valve atresia, and we have to look for the aortic valve lesion. So there are the 3 things we have to, we have to correct. So that's a 3-stage surgery, or simply we can say we should go for heart transplantation. We're coming towards truncus arteriosus. Truncus arteriosus occurs when a single trunk emerges from both right and left ventricle. Right ventricle giving off this pulmonary trunk, and the left ventricle is giving off the aorta. But instead of giving these two, if there is only one single trunk emerges, that means you won't be able to differentiate whether it's aorta or it's a pulmonary trunk. You can say it's just a truncus arteriosus, right? From both the right and left ventricle, and give rise to all major circulation. So you won't be able to distinguish whether it's a pulmonary trunk or it's a aorta. And rather than that, there is only one trunk, that is known as truncus arteriosus. Now presentation is symptom occur within the first few days of life and are characterized by there will be severe dyspnea, there will be severe difficulty in breathing, early and frequent respiratory infections we are going to see because there is a lot of contamination of the blood here. Single S2 is heard as there is only one semilunar valve, and a systolic ejection murmur is heard because these valve leaflets are usually abnormal in functionality and peripheral pulses are bounding. So we have only one trunk here, so we are just going to hear single S2, and the pulses are the bounding one because of the high pressure. Now for the diagnostic testing, chest X-ray will show cardiomegaly with increased pulmonary markings. So we'll see the cardiomegaly, we'll see the pulmonary markings, increased pulmonary markings. So pulmonary markings are increased, and the chest X-ray will show cardiomegaly. Now for the treatment part, the most severe sequelae of this condition is pulmonary hypertension, which will develop within 4 months. Within 4 months of time period, because the most severe sequelae, the most severe thing which is occurring here in this patient is pulmonary hypertension, which will develop within 4 months. So within the time period of 4 months, we can see the pulmonary hypertension in a patient. So surgery must be completed early to prevent pulmonary hypertension. So why we want early surgery? Because we don't want our patient to go into pulmonary hypertension, right? Why? Because pulmonary hypertension is one of the most severe sequelae of this condition. After having this truncus arteriosus, we should correct it as soon as possible. Otherwise, the patient can go into pulmonary hypertension, and then surgery must be completed early to prevent pulmonary hypertension. That's important. Alright, then we have this total anomalous pulmonary venous return. Total anomalous pulmonary venous return, a congenital condition is which there is no venous return between pulmonary veins and the left atrium. There is no venous return between pulmonary veins and the left atria. Left atria is, these pulmonary veins are actually opening into the left atrium. These pulmonary veins are carrying oxygenated blood from the lungs, and they are giving that oxygenated blood to the left atria giving it to the left ventricle giving it to the aorta is supplying to the whole body, and the whole body contaminated blood is coming by inferior vena cava and superior vena cava into the right atria, from the right atria into the right ventricle, from the right ventricle into the pulmonary trunk, from the pulmonary trunk into the lungs. They will oxygenate the blood and will send it to the left atria again with this pulmonary veins, right? So this is all about the circulation. But in case of total enamelus pulmonary venous return, what is actually the major defect? There's a congenital defect in which there is no venous return between pulmonary veins and the left atria. Oxygenated blood instead returns to the superior vena cava. Superior vena cava should enter into the right atria. So pulmonary veins should enter into the left atria, but instead of opening into the left atria, pulmonary veins are opening into the right atria, and not exactly the right atria, actually into the superior vena cava. So this is known as total enamelus pulmonary venous return. And there are two forms, with or without obstruction of the venous return. Obstruction refers to the angle at which the veins enter the sinus. So if the vein entering into the sinus in such a way that the sinus is obstructed, that is known as obstruction, right? So that's important, with or without obstruction. So we'll see total enamelus pulmonary venous return with and without obstruction. So if we are considering with obstruction, what are the signs and symptoms, how we're going to diagnose, how we're going to treat. So in case of with obstruction, there is early in life with respiratory distress and severe sinus. Of course, if there is obstruction, you will see distress, you will see respiratory distress, you will see severe cyanosis, right? And right from the beginning of the life. So early in the life, you're going to see cyanosis, and early in the life, you're going to see respiratory distress. How you're going to diagnose? You will go for the chest X-ray first. Chest X-ray show pulmonary edema. Echocardiography is a definitive one. Again, you see, the second time it's repeated, the chest X-ray is going to be the initial testing, and echocardiogram is considered to be the definitive test. For the treatment option, surgery is the definitive choice for the treatment. So of course, it's an obstruction. So if it's an obstruction, we don't have any choice rather than surgery. We have to go for surgery if there is obstruction. Then we have total enamelus pulmonary venous return without obstruction. So if it's without obstruction, so first of all, the symptoms are age 1 to 2 years with right heart failure and tachypnea. So if it's without obstruction, again, it's okay, obstruction is not there, but again, there is total enamelus return. Instead of opening into the left atria, the pulmonary veins are open into the superior vena cava. So as a result, we are going to see right heart failure and tachypneic, difficulty in breathing, and high respiratory rate. Chest X-ray shows snowman or figure 8 sign. This is very important. If you see the snowman sign, if you see the figure 8 sign, that is actually pathognomic for total enamelus pulmonary venous return without obstruction. Most accurate diagnostic test is an echocardiogram. Again, most accurate is the echocardiogram, and the initial one is chest X-ray. So in case of with obstruction, you will see pulmonary edema in chest X-ray, and in case of without obstruction, you will see snowman appearance or a figure of 8 sign, right? Now, diagnose echocardiogram, diagnose the echocardiogram and not by the X-ray. Of course, we have to go for the most accurate one for the final diagnosis. So we will do the echocardiogram, and then we will decide that, yeah, this is total enamelus pulmonary venous return without obstruction. Then for the treatment option, we have surgical intervention to restore proper blood flow. So definitely, although it's without obstruction, but we have to go for surgical intervention to restore proper blood flow. So whether it's with the obstruction or without obstruction, we have only surgical options. In case of with obstruction, definitive surgical choice, but in case of without obstruction, we have surgical some interventions. Why we are opting for these interventions? To restore proper blood flow. Alright, now we're coming towards tricuspid valve atresia. See, atresia, narrowing of the tricuspid valve. Where are the tricuspid valve? Tricuspid valve are in between the right atria and the right ventricle. So tricuspid valve atresia presents as severe cyanosis in a newborn. The lack of communication between the right heart chamber results in a hypoplastic right ventricle and pulmonary outflow tract, and consequently underdevelopment of the pulmonary valve and or artery. See, the lack of communication between the right, if there is atresia, because tricuspid is in between the right atrium and the right ventricle, if there is a lack of communication between the right heart chambers, that's the right atrium and the right ventricle, then what will happen? There will be a result in hyperplastic right ventricle. Right ventricle will be hyperplastic, and as a result, pulmonary outflow tract will also become hyperplastic, and consequently underdevelopment. Pulmonary valve will not be developed so much because pressure is not there, because there is atresia, there is narrowing, the blood is not properly reached to the right ventricle. So as a result, from the right ventricle, the blood is not properly reached into the pulmonary trunk. That's why pulmonary trunk, all that will be hypoplastic. The patient with tricuspid valve atresia must also have an associated congenital. There must be some other association. It's not like that tricuspid valve atresia is always, you will find this alone. No, if there's a case of patent foramen ovale, in that patient also we can see the tricuspid valve atresia. In case of ASD, in case of VSD, we can see this tricuspid valve atresia. So there are many things which are actually found together, or they would not be alive. This additional abnormality allows for mixing of oxygenated and deoxygenated blood, enhance the infant survival. So this is how, because 2-3 things are there, this is how the infants actually survive, right? So this oxygenated and deoxygenated mixing, of course, is there in case of VSD, in case of ASD, in case of patent foramen ovale. What are actually occurring in all these conditions? There is contamination of blood, there is mixing of oxygenated and deoxygenated blood in all these cases, in PFO, in ASD and VSD. In VSD, right and left ventricle bloods are mixed together. In ASD, right atrium and right ventricle blood are mixing. In patent foramen ovale, again there is mixing of the atrial blood. So, chest X-ray will show decreased pulmonary flow. If we go for the chest X-ray, first we'll see this decreased pulmonary flow, and when we go for the ECG, we'll confirm left axis deviation and smaller absent R wave in the precaudal leads along with left ventricular hypertrophy. So here we'll confirm it with the help of ECG or EKG electrocardiography, in which we will see the absent R wave or left axis deviation and left ventricular hypertrophy. So left ventricular hypertrophy. Ventricles, left ventricle will be hypertrophied, but there will be hypoplastic right ventricle. So that we can see on the basis of ECG or EKG, right? Now for the treatment part, we have prostaglandin E1 to keep the PDA open until an aortopulmonary shunt can be performed. You remember, we can't give indomethacin and NSAID because they will close this ductus arteriosus. Rather, we can give this prostaglandin E1 actually, that will help to keep the PDA open until an aortopulmonary shunt can be performed. Possible atrial balloon septostomy to enlarge the ASD. If we want to enlarge the ASD, we can go for this septostomy. We'll create a mouth in the septum by the help of balloon in the atrium, and that is known as atrial balloon septostomy. Or we can go for the staged surgical correction, 1-by-1 correction. Alright, so I'm just going to stop here. So tomorrow we'll continue with this acyanotic lesion. Thank you.